Right. Go ahead.
Good evening, everyone. This is Batul from IGCP, and I would like to welcome all the viewers who have joined our platform for the better exchange of knowledge that is going to be shared by our renowned speaker who is here with us today. With great honor and pleasure, I would like to introduce a very renowned internal medicine, Dr. Kumar Prafula Chandra, sir. Sir is MD in Medicine, DFID, CMC Vellore, MSc in Advancing Diabetes Care, UK, Director at the Department of Internal Medicine and Diabetes Care, Health City Vistar Hospital, Gomti Nagar, Lucknow. Sir is also the Director at Chandra Diabetes and Obesity Clinic, Vedanta Khan, Gomti Nagar, Lucknow. With the help of Sir, we'll be taking a close look on today's topic, which is management of hyperglycemia in type 2 diabetes, ADA ESD Part 2. So, before moving on to today's session, let us have a brief look on what the topic says. The American Diabetes Association regularly releases updated guidelines and recommendations to assist healthcare providers in delivering optimal care to their patients. The ADA 2023 focuses on the rationale behind global glucose lowering treatment, emphasizing its significance in achieving glycemic control and reducing the risk of complications associated with diabetes. This series provides valuable insights into the evolving landscape of diabetes management, incorporating new research findings, clinical trials, and evidence based approaches. We'll be learning more about the role of ADA guidelines in the advancement of diabetes treatment with Sir's wonderful knowledge and his wonderful inputs. So, now without any further delay, I would like to welcome Sir at our forum and would like to hand over the session to him for his talk to begin. Sir, over to you.
Thank you very much, Batul, for a kind introduction. Thank you, IJCP, for giving me this opportunity. So, good evening, ladies and gentlemen. Today we are going to talk about the therapeutic options, lifestyle, healthy behavior, weight management, and pharmacotherapy for treatment of type 2 diabetes. So, basically, this is a series that we have started. As told that ADA and EASD releases guidelines for the management of hyperglycemia in type 2 diabetes every year, and it gives us a depth of knowledge about how the approach should be. In our part 1, we did try to understand what is the rationale for managing diabetes, why we should treat diabetes, and then how we should involve the patient, how we should communicate with the person living with diabetes. The first encounter with the person with diabetes is very important. We need to understand their expectations, and then we need to personalize the health care which suits best to the person. Thus, we need to involve them in decision making. We need to involve them in treatment part. And once the person living with diabetes is involved in the decision making, it improves their behavior towards treatment. Once person understand what is the requirement, why should they get treated for diabetes, they understand it better, and that improves the compliance. And then we need to personalize the therapy depending upon the acceptability, depending upon the financial aspect, depending upon the comorbidities, complications, and other issues associated with diabetes. So this is what we learned in part 1. In part 2, we will be talking about therapeutic option, so the interventions that we need to do so that we are able to help people living with diabetes. The first thing that starts in the management of diabetes, after proper counseling, proper involvement of the patient, what we call is self management of diabetes, empowering them for diabetes. The second step that comes in is lifestyle modification and healthy behavior. So there is a very common requirement, and what I say to all people come to me who come to me for help for diabetes, I say that lifestyle and healthy behavior is the basis of treatment. Whatever medication you take, whatever insulin you take, whatever drug you take, that may control your blood sugar. But if you have to modify the course of the disease, it is the lifestyle and your behavior, health behavior, that is going to have a long term impact on that. So the first thing is lifestyle behavior, and healthy behavior, which we really discussed in detail. We will be discussing again. Now, the second part which we are going to talk about is weight management. We'll try to understand what is the status of problem of obesity, why weight management is beneficial in treating diabetes, why weight management is put even before pharmacotherapy. Importance of weight management has improved drastically in past 1 decade thanks to many clinical trial on lifestyle modification and weight management that improved the overall outcome, overall the markers of diabetes control, and that's why a lot of insight has come in about weight management, and we will try to understand that. At the end, I will be talking about pharmacotherapy, which drug has to be chosen in which condition, what are the pros and cons of each category of the drug, when we should use it and when we should not use it. So thank you very much once again for joining this talk. Let us begin with our first topic, that is why weight gain, why weight loss, why weight management in type 2 diabetes. So this is the fact about US population. Almost 50% of the population is going to be diabetic, that is going to be obese by 2030, and around 25% of them will have morbid obesity. But let me tell you, the story is even worse for India. We all know Indian population are thin fat. So the cutoff value of BMI for obesity in Indian population is 25 against 30, which is for US population or world population or WHO criteria. And if we put that, let me tell you that around 40 to 45% of people living in India are already obese. So we are no more a malnourished country with low body weight. Almost 50% of people living in India are also obese as per the standards of Indian population. So this calls for action, and action has to be appropriate. Let me give you an update from World Obesity Atlas that says that by 2030, about 1 billion people, can you understand? 100 crore people will be obese. And the rate with which obesity is increasing drastically. So it is not limited to uh, rich countries, but it is increasing at greater number. So greater number of people living with obesity are there in low and middle income countries, and these numbers are doubling across. So the rate with which the incidence of obesity is increasing is very, very alarming even in low and middle income country. Now, this was the status of obesity. Why to treat obesity? So this is a result from direct randomized control trial in which intensive weight management was done in one group compared to standard treatment and standard counseling in the other group. And you can see the results. In those people in which there were intensive structured weight management, they had significant weight loss, and you can see at the end of 1 year and 2 year in the control arm compared to intervention arm, more than 15 kg weight loss was seen in up to 24% of the people in whom intervention was intensive. Now let us move to another aspect. Decrease in weight, did it help in diabetes? And answer is yes. Once again, you can see the control arm and intervention arm. Whereas only 24% of the patient achieved weight loss of more than 15 kg, you can see around 50%, 45.6% of the people did get, in those who were in intensive arm for weight management, there was a remission of diabetes. Now let us distribute it according to weight loss. So when weight loss was less than 5 kg, remission was around 5%. When weight loss was in between 5 to 10 kg, weight loss was around 30% of the people. So 10 30 out of 100 people did get remission in diabetes. When weight loss was in range of 10 to 15 kg, remission in diabetes was around 60%, and when weight loss was more than 15 kg, around 86 to 75 to 80 to 85% people did get remission in diabetes. So what we learn out of this, that if we manage weight, if we are able to decrease body weight by around 10 kg in obese person, there are 64% chance that diabetes will go in remission. Remission means patient does not require treatment. You have already treated diabetes. He will not require tablets. So you treat the pathophysiology, you treat the weight, you decrease the weight, and up to 64%, two-thirds of the patient would have a remission in diabetes and will not require treatment. And that's why weight management has come very, very upstream in management of diabetes. Now, moving to interventions and results that we do have. So there are certain drugs which has come up, particularly GLP-1 agonist, GLP-1 receptor agonist, and a new drug GIP and GLP-1 receptor agonist combined. So GLP-1 receptor agonist, there are a group of drug. What I'm going to talk about is semaglutide. This semaglutide in step 2 trial was given at different doses, 1 milligram and 2.4 milligram once in a week, and you can see the impact on body weight. With 2.4 milligram, there were about 10% decrease in body weight. So, yes, weight loss can happen. Weight loss can happen with lifestyle intervention, and there are drugs also. There are safe medications also which help in weight reduction, and semaglutide is one of the most potent amongst them. Now, comparing the other drug, terzepatide, which has come. Now, this was compared with 1 milligram of semaglutide, and you can see the result once weekly. Here also, weight loss is more than 10 kg, that is 12.4 kg in topmost dose. And percentage of patient who met weight loss more than 5% was up to 80%. So 80% of the population had weight loss more than 5%, and up to 60% of the population had weight loss of more than 10%. So this is the huge impact. So what we understand, weight loss causes a remission of diabetes. More than 10% weight loss, chance of remission of diabetes is about two-thirds of patient of the population, and there are drugs available which are able to achieve weight loss more than 10 kg. Now there have been strategies. These drugs have come up in past 1 decade, but there have been surgical strategies also by which weight loss was done. We all call it metabolic surgery, which include gastric bypass surgery, Royan gastric bypass surgery. So there are two, three types of surgery which is done. RYGB is the most popular. And what you see here, with this surgery, weight loss occurs. And with weight loss, glycated hemoglobin comes down to near normal. That is the wonderful. So ultimately, weight loss leads to improvement in glycemia. What we have seen that even at those time, medications were able to decrease weight loss, because at that time this tirzepatide, semaglutide, and SLDT2 inhibitors were not used. So in comparison to medication, weight loss by surgery was quite more in the comparison arm. So what we understand, for weight management goal, we should achieve and maintain the goal. So first thing that we need to have, you have to individualize the weight management. You have to find out what is the target weight for that person who has come to you. And when you start weight management, it should start with general lifestyle advice, which include medical nutritional therapy. So what we need to talk to them, we need to educate them about what is the caloric requirement. We need to tell them how to calculate the calories. We need to set a caloric as per their lifestyle. They will require, say, X amount, 1200 calories or 1500 calories. So according to their lifestyle, what is the calorie requirement? Then you need to give some negative calorie balance, say 200 calories or 300, and then you need to educate them about how to calculate the calories. So In addition to calculating calories, he is taking adequate nutrition also in terms of vitamins, proteins, and fat. So, this is how you have to personalize the medical nutritional therapy. You have to educate their eating behavior, physical activities. I would be discussing further. Then we have to go for intensive evidence based structured weight management. So, in addition to lifestyle intervention, choose the drug which has got evidence of decreasing body weight. We need to consider weight loss by medication, and when medication fails, particularly those patients who are morbidly obese, we would require metabolic surgery also. So, when we are choosing glucose lowering therapies, we have to consider those drugs which has got high to very high impact on glucose and weight. So choose those drug which decreases body weight, which decreases glucose. So this is how, if a obese person living with diabetes comes to you for the management, the first goal has to be weight management. Start from lifestyle intervention. Use those drugs which has got high or very high if impact on glucose and weight bearing. So when we talk about lifestyle or physical behavior, this is 5S that we need to understand. Throughout the day, what do we do? Activities. We might be walking, we might be sleeping or lying down, we might be sitting, doing some work in office, or we might be sweating, doing some physical exercise, or we might be doing some strength training. So when I talk about physical behavior, I can imagine these 5 positions that a person may have. He could be sleeping, he could be sitting, he could be standing or walking, he could be walking or doing some exercise, or who could be in gym and doing some strength training. Let us understand each aspect one by one. It is said that sitting is equivalent to smoking. If you sit continuously for more than 8 to 10 hours, that is equivalent to one severe risk factor. So it is said that we should limit sitting, but there are job related compliance which makes us sit for long duration. So what it is said, that we should break the prolonged sitting, preferably every 30 minutes, with short regular bouts of slow walking, simple resistance exercise. And it has been seen that if you just take a break of 5 minutes every 30 minutes, just go for a walk or simply stretch yourself for a couple of minutes, it improves glucose metabolism. So this is how it is going to improve. Now come to sweating. Sweating means moderate or vigorous exercises. It is said that more than 150 minutes per week of moderate intensity of exercise should be done. If you are going for vigorous exercise, it should be done at least 75 minutes per week. Now you can split these exercise into 3 parts or 5 parts, but there should not be no more than 2 consecutive days of inactivity. Evidences are there that as little as 30 minutes per week of moderate intensity exercise improves metabolic profile. This doesn't mean that I'm saying that do 30 minutes only once a week. Benefits starts right from 30 minutes. It is recommended that you should do more than 150 minutes of moderate intensity exercise. There is another important aspect that we need to understand. With obesity comes sarcopenia. And what we talk, that as we age, we do get sarcopenic obesity, meaning thereby our weight keeps on increasing, but our muscle mass keeps on decreasing. Muscle mass is actually metabolic capacity, which improves our metabolic profile, and fat mass is the metabolic load. But what we have seen, that with aging, this metabolic load increases, and that leads to improper metabolic profile. Now, the story is a little bit more when patient has got diabetes. It has been seen that all the sarcopenic condition occurs almost a decade earlier. So, if I am a 50-year-old person with diabetes, my muscular strength will be of a 60-year person who doesn't have diabetes. Or if I am a 40-year young man with diabetes, my muscle strength will not be equivalent to 40-year-old person without diabetes. It will be equal to 50-year-old person without diabetes. So 1 decade earlier, my muscle strength goes down, and all those metabolic profile gets disturbed. So we need to educate our muscle, we need to train our muscle with moderate intensity exercise, and that is what I was telling, that the pathophysiology which has affected our muscles should be done. Now comes walking. For our day to day activities we keep on walking, and data have said that as small as 500 steps per day decreases the cardiovascular and mortality. So as you keep on increasing, say if you are walking 2000 steps per day, you walk 5000 steps per day, cardiovascular mortality and mortality will decrease. That is how every 500 steps per day increase leads to decrease into 2 to 9% decrease in cardiovascular morbidity. And even 5 to 6 minutes of brisk intense walking per day increases your life expectancy by 4 years. So if a person is purely sedentary and say he walks for 10 minutes per day, brisk walking, his life is increased by 4 years. That is the importance of stepping. So I talked about sitting, I talked about sweating, I talked about stepping. Now let me talk about strength training. Resistance exercise is equally important. It gives you balancing. It gives muscles their strength. It improves the metabolic profile of the muscles. And that ultimately improves the insulin sensitivity and helps in keeping glucose level controlled. And any type of exercise, strength exercise or muscle strengthening can be used. It can be tai chi, it can be yoga, or it can be going to gym, weightlifting, controlled weightlifting. Don't go for things beyond your control. And last but not least, sleep. Quality of sleep is really very important. Having a pleasant uninterrupted sleep even on weekends has got beautiful impact. Quantity of sleep, a sleep duration of at least 6 to 8 hours or sleep duration in between 6 to 8 hours are required at night, because if you get a good amount of a good quality sleep, it has got negative impact on HbA1c. HbA1c decreases. It decreases the sympathetic tone, so counter-regulatory hormones decrease, then HbA1c decreases. However, if duration of sleep is less than 6 hours or more than 8 hours, then it will lead to increase in HbA1c. Quality of sleep is important. Irregular sleep results in poor glycemic level. So we have been looking at obstructive sleep apnea, people who get interrupted sleep. They do have hypertension, they do have diabetes, they do have dyslipidemia. All those things are increased. So this irregular sleep result in poor glycemic level, likely influenced by increased prevalence of insomnia, obstructive sleep apnea, restless leg syndrome. And then comes chronotype. When do you sleep? Do you sleep early and get up early, or do you sleep late and get up late? So, night owls or those people who go to bed late, get up late, may be more susceptible to inactivity and poor glycemic level. Whereas morning chronotype, that is early birds who go for to bed early and get up early, they have got better glycemic control, they have got a better activity profile. So this is how it is going to affect. Now, moving to drugs. So we have talked about physical activities, we have talked about importance of weight loss. Now, medications. What are the things? So any treatment of diabetes begins with metformin unless it is contraindicated, because we have got decades, more than 5 decades experience with metformin. So traditionally metformin is recommended as first line glucose lowering therapy in type 2 diabetes unless it is contraindicated, because it has got high efficacy with no risk of hypoglycemia. It has got potential for modest weight loss, although neutral many times. It is it has potential benefit in adverse cardiovascular event, neutral for heart failure, neutral for diabetic kidney disease. However, it is contraindicated when eGFR is less than 30 because of the fear of lactic acidosis. It is available orally, and the most important thing is its cost is very low. So you have got a high efficacy drug with low risk of hypoglycemia, no risk of weight gain, orally available, low cost therapy. And that is why all these features make metformin the drug of choice or first drug which has to be used in patients with diabetes. Then comes sulfonylurea. Once again, very old molecule, decades of experience, has got high glucose lowering efficacy. Once again, the cost is low and it is easily accessible, orally available. However, there are heterogeneous group of sulfonylurea, and we have to choose only those sulfonylurea which has got lesser risk of hypoglycemia. And that's why second generation sulfonylurea is what we choose. But there are certain negative aspects of using sulfonylurea. There is risk of weight gain, there is risk of hypoglycemia, and thus you have to use it judiciously. It is neutral for MACE and heart failure. There have been trials which have said that it is neutral, which is comparable to linagliptin. However, when there is a renal compromise, dosage has to be adjusted because risk of hypoglycemia increases with that. Now I move to the third drug which is commonly used. This is thiazolidinedione. For all practical purposes, it is bioglitazone. Rosiglitazone was banned. Now, this drug has got high efficacy and it is very much durable. We all know about oral anti-diabetic failure. You start one medicine, after a couple of years, you will see that medicine is not able to give adequate glycemic control. And that is called durability of glycemic effect. Pioglitazone or thiazolidinediones has longest durability of glycemic effect. This makes this drug very good. It has got potential benefit in major adverse cardiovascular event, but this drug causes fluid retention and weight gain, so it increases the risk in patients who has got heart failure, or even in those patients, although it is not contraindicated in diabetic kidney disease, but we all know that kidney disease is associated with fluid accumulation, and pioglitazone will lead to increase in fluid accumulation and worsening of the heart failure. So it is rather not used in diabetic kidney disease and heart failure patients. It is orally available. So when you think of using pioglitazone, try to combine it with those drugs which are known to decrease the body weight or which are known to increase the fluid loss, like SGLT2 inhibitor. They promote weight loss, they lead to sodium excretion. So you can combine thiazolidinediones with SGLT2 inhibitor so that they counteract their adverse side effect. Now moving to newer drugs, I will say DPP4 inhibitor. Once again, experience is more than 1 decade, nearing 2 decades. This has got intermediate efficacy, but safety profile of DPP4 inhibitor drug is really very good. Risk of hypoglycemia is low, weight change is neutral, neutral for MACE, heart failure neutral, except of one. So this drug relatively don't have any side effect. This is usually well tolerated. And you have to choose this drug appropriately in those patient population where follow-up may be questionable, or where risk of hypoglycemia is more. Then you need to choose those drug where side effect profile is very low. And let me tell you, there are results which has said that if you combine metformin with DPP4 inhibitor, the trial was with vildagliptin, that say that durability is also increased. So if you combine these drugs immediately to begin with, durability in the glycemic control is quite good, and all of them are safe. Now moving to the latest couple of drugs. One is SGLT2 inhibitor, that is sodium glucose linked transporter 2 inhibitor. We have been using it for past 1 decade, and as the time has passed, we have got a lot of experience, which has made SGLT2 inhibitor as a most prescribed anti-diabetic drug just after metformin in modern prescription. How does it work? So it reduces renal tubular glucose reabsorption. Its clinical efficacy is intermediate to high glucose lowering. However, efficacy is less when EGFR is low risk of hypoglycemia, and there is intermediate weight loss. I talked about weight loss, drugs which cause weight loss. SGLT2 inhibitor is one of them. Over the time, in different study and trial, what we have seen that SGLT2 inhibitor leads to reduction in major adverse cardiovascular event, reduction in overall CV death, reduction in risk for hospitalization due to heart failure, reduction in risk of kidney outcomes. Thus, increased confidence about safety issues has come. We are using this drug more and more. It is being given oral. However, its cost is high. But many drugs have become off patent, particularly DAPA after dapagliflozin becoming off patent. This drug is now accessible to most of the patient, and we can pass the benefit of weight loss, improved insulin sensitivity, improvement in cardiovascular event with use of SGLT2 inhibitor in patients who need it. Now moving to another group of drug, that is GLP-1 receptor agonist. So GLP-1 receptor agonist, how do they work? They augment glucose dependent insulin secretion. They lead to glucagon suppression. They delay the gastric emptying. They curb the post-meal glycemic increment. They reduce the appetite. They reduce the calorie intake, and thus they reduce the body weight. So calorie intake is reduced. खाने का मन नहीं करेगा, पेट बड़ा बड़ा रहता. Ultimately, that leads to weight loss. Their efficacy is high to very high. Glucose decrease by GLP-1 receptor agonists are high to very high with a very low risk of hypoglycemia. It also leads to significant intermediate to high weight loss. Its safety has been proven. However, in addition to safety, it has got beneficial effects also. Beneficial effect on renal outcome in CVOT trial, which was driven by albuminuria. So reversal of albuminuria was being done by dulaglutide, liraglutide, and semaglutide. Beneficial effect on major adverse cardiovascular event was seen by dulaglutide, liraglutide, and semaglutide. However, this drug is mostly available as injectable subcutaneous, except semaglutide oral formulation. So semaglutide is available both as subcutaneous and oral. Oral is only semaglutide. Rest all GLP-1 receptor agonists are only available as subcutaneous injection. The cost is high. However, there are certain conditions where you have to be cautious. Apart from allergy, if patient has got too much of GI disturbances, patient with renal dysfunction, where GI disturbance can exacerbate renal dysfunction. So those are the places where we have to be careful. And of course, if patient is very poor, he can't afford, you have to be careful. So we do have a drug which is safe, has got robust glycemic effect, has got robust effect on the weight change, and that is why GLP-1 comes in. Few words about GLP-1 receptor agonist therapeutic update. This is oral semaglutide. Trials have been done. Pioneer series of trial was done. As monotherapy, comparison with empagliflozin, comparison with sitagliptin, comparison with liraglutide. Then with other oral anti-diabetic drug, this drug has also been, studied in advanced type 2 diabetes patients who are already on insulin. The drug has not been only found safety, it is safe. In addition to safety, they have got robust HbA1c reduction, which was far more than the comparators which were being used. Some other, apart from semaglutide, there is dulaglutide. You can see the results are here also beneficial. So dulaglutide, semaglutide, weight loss and glycemic effect are well proven. Now, another drug of interest, which is the latest drug, it is tirzepatide. This is glucose-dependent insulinotropic polypeptide (GIP) receptor and GLP-1 receptor agonist. So dual receptor agonist. Surpass series of trial was done in which robust reduction in HbA1c, robust reduction in body weight was seen. HbA1c reduction in the range of 2 to 3% was seen in these series of trials. So if I try to summarize Tirzepatide, its mechanism of glucose lowering is GIP receptor and GLP receptor agonist. Thus, it enhances the first and second phase insulin secretion. Glucose mediated insulin secretion reduces glucagon level, both in glucose dependent manner. Its clinical efficacy is very high in terms of glycemic efficacy with very low risk of hypoglycemia. Weight loss is high, and as far as cardiorenal protection is concerned, studies are still underway and we can't claim anything as of now. Now we move to the last and the oldest drug, that is insulin. Insulin is the actual hormone which decreases blood sugar level. Whatever thing that you are doing, either you are trying to increase the insulin level or increase the insulin sensitivity or decrease the insulin requirement. So the understanding of diabetes was based on the fact that insulin as a hormone has to be given or its impact has to be improved. So we do have evolution of insulin more than 1 century. I mean, we are 102 years when insulin was discovered. So the advantage of lowering glucose is dose dependent manner and is able to address level of glucose at any level. Blood sugar level 600, 800 or 200. Insulin is a drug which will work at each and every level. And that will be in a dose dependent manner. Higher the sugar level, higher the dose required. Lower the sugar level, lower the dose required. Sky is the limit for the dose. However, there is increased risk of hypoglycemia with high glycemic efficacy. There is a risk of weight gain also, and it is neutral for cardiorenal profile. Efficacy and safety is largely dependent on education and support facilities. So a proper education of the patient has to be done. Insulin training has to be done so that patient is able to monitor the dose properly. And then when you use insulin, you have to use insulin in such a way that you can mimic the physiological requirement. And this is what the picture in this slide says. Normally, we do have a basal insulin requirement which controls hepatic gluconeogenesis and keeps our blood sugar at a constant level. Whenever we do take meal, there is spurt in the glucose level and simultaneously internal insulin secretion also increases, which controls the blood glucose level. The challenge was that we should have an insulin which mimics the endogenous insulin. So over the time, type of insulin has changed. So we have developed insulin analogs, which were first intermediate acting, then they came long acting, then ultra long acting, which tries to mimic the basal insulin. Then the other part was fast acting, short acting insulin, then fast acting insulin, then rapidly acting insulin has come, which is trying to mimic the prandial insulin release. So once we have understood the different group of drugs that can be used, let us understand need of combination therapy. So gone are the days when we used to tell that do first lifestyle modification, then use metformin, then once metformin fails, then you add second drug. So at those times we were treating to fail. Now we are treating for a long-term control. So when you combine the therapy, it has got increased durability on the glycemic effect. So risk of OAD failure is decreased. Plus, it addresses the therapeutic inertia. 3 महीने में शुगर कंट्रोल नहीं, अच्छा 3 महीने और देख लेते हैं, 3 महीने और देख लेते हैं. तो what it used to, because of this therapeutic inertia, patient used to remain exposed to high glucose level, leading to bad glycemic memory. So this combination therapy has helped in decreasing therapeutic inertia, increasing glycemic durability, preventing bad glycemic memory, and thus preventing complications associated with that. The combination therapy simultaneously targets multiple pathophysiological processes characterized in type 2 diabetes. It has got potential impact on medication burden. So number of tablets are decreased. That leads to treatment persistence. So compliance is improved. And there are certain drugs which has got complementary benefit. One has got benefit, I was just telling you, if you have to use bioglitazone, use with SLDT2 inhibitor. So glycemic effect, weight loss, cardiovascular risk profile. So when you use combination therapy, you are trying to target the pathophysiology, having longer glycemic durability with better compliance and long-term benefits. Though, so that's why combination therapy is now promoted in most of the time when we are treating diabetes patients. So I would like to summarize the things how to achieve good glycemic and weight management goals in patient. So you have to individualize the therapy. For glycemic management, choose the appropriate drug that provides efficacy and achieves the goal. So metformin or agent including combination therapy should be used. In general, high efficacy approach includes combination therapy or GLP-1 receptor agonist or GLP-GIP receptor agonist or insulin. High, very high, and then intermediate. DPP4 inhibitor has got intermediate impact. Similarly, simultaneously, in addition to glycemic management, we should always target weight management. Weight management would include general lifestyle advice, then intensive evidence-based structured weight management, and drugs with very high weight loss if potential includes semaglutide and tirzepatide, dulaglutide and liraglutide, that is other GLP-1 receptor agonist, has got high weight loss potential. Intermediate weight loss potential is with SGLT2 inhibitor. Weight neutrals include DPP4 inhibitor and metformin. So in an obese person where weight is a cause, two drugs, sulfonylurea and TGDs, that is bioglitazone, would lead to weight gain and should be avoided. Insulin is another drug which should be not given in these drugs if other modalities are well tolerated. Thank you very much for your patient hearing.
Thank you so much, sir, for your wonderful inputs upon the topic that you have shared today with us. We have received few questions from the participants, and I would like to put it across to you. The first question is: does hyperglycemia caused by infection stress affects the severity of pneumonia in non-diabetic people?
Of course, there are studies which suggest that those patients who develop hyperglycemia during admission have worse outcome. So if I have to categorize patient into two, three group, one is patient who doesn't have diabetes, who do not develop hyperglycemia, they will have best prognosis. Another group is diabetic patient who is well controlled on medication and therapy even during surgery. Number two would be that. Number three would be diabetic patient who are on treatment but have poor control. And number four will be those patients who didn't have diabetes or who didn't have diagnosis of diabetes, and during the emergency or infection they have been diagnosed to have diabetes. They do have worse prognosis. So the impact of hyperglycemia, stress induced hyperglycemia during hospitalization due to emergency, it has got negative impact on duration of hospitalization and overall outcome. Thank you.
Thank you so much, sir, for answering this question. We'll move to the next question that we have received. And the next question is: can drug therapeutics based on natural products be more beneficial in health management of diabetic patients dependent on insulin?
See, unless we do have data to support it, whatever it is, yesterday I was talking about all these things and I told ki, well, generate data, generate evidence. When you say probably this is the mechanism, this may help, and when you say this will help, that makes a huge difference. So when you talk about natural products for which we don't have evidence, I don't say they are not going to help. They may help. But if I do have a medication with which I have got evidence, I have got proof, I will say this will help. So that is the narrow line that you have to understand. If you are using some intervention and you do have evidence to prove it, you will have confidence that I'm doing the right job. And if you are using some natural product about which you don't have adequate Scientific evidence, you will always say it may help, I don't know. That is the difference. Thank you.
Thank you so much, sir, for answering this question. We'll move to the next question. And the next question is, why insulin is given in type 2 diabetic patient as it is insulin resistant diabetes?
So you have to understand the mechanism. Diabetes develops when, in type 2 diabetes also, the basic pathophysiology was insulin resistance. So to compensate the insulin resistance, our beta cell started functioning more. So initial stage there was hyperinsulinemia. A stage comes when this beta cell gets exhausted. So when your beta cell capacity decreases below 50%, then you start developing diabetes. So type 2 diabetes has got both type of insulin deficiency in terms of amount of insulin that is required, and the way insulin works. So insulin sensitivity is decreased, amount is decreased. So there comes a stage when the insulin secretion is decreased to such a low level that whatever drug you use to improve the insulin sensitivity, that is not adequate to control the diabetes. And that is what we call, in type 2 diabetes also, patient has become insulinopenic. And when patient becomes insulinopenic, insulin has to be given. Apart from that, there are certain conditions in type 2 diabetes which requires insulin immediately. Acute condition, hospitalized condition, where you need to bring the blood sugar level to the normal range very much quickly, you need to have insulin. So these are the conditions where insulin are required in management of type 2 diabetes, and this is the basis for requiring insulin. Thank you very much.
Thank you so much, sir, for answering this question. We'll move to the next question for today's session and the last question for today's session. And the question is, do you have any observation that topical glucocorticoid very prolonged over 10 years use hand dermatitis can cause diabetes mellitus?
Less likely. Of course, I don't say that when you use topical corticosteroid, there is no absorption, but with use of topical corticosteroid, systemic absorption is very low. Risk, theoretical risk of developing diabetes with long-term topical steroid use do exist, but it is less common in comparison to oral corticosteroid or systemic corticosteroid being given. Thank you.
Thank you so much, sir, for answering all the questions. That was the last question for today's session. And at the outset, I would like to thank all the viewers who have stayed here with us throughout the session and have got the knowledge that they were here for. So thank you so much to all of them for their patient listening. And I would also like to thank you, sir, for taking out your valuable time and for being here at our platform and sharing such wonderful inputs and continuing the series with your wonderful knowledge about it. So thank you so much for that, sir.
Thank you very much, Batul and IJCP, for giving this opportunity. Next 22nd July, we will have part 3 of the ADA series, and I will be sharing the topic as soon as possible. Thank you.
Thank you so much, sir. Thank you. With this, we are concluding the session here for today. Until next time.